So good evening, everybody, and my presentation really is a follow-on from what a colleague of mine has presented already, Josephine. She's presented the difficult, hard stuff in terms of the numbers and the statistics and the evidence, and mine is to do a very simple, quick job of describing how we are doing the community mobilization and to take you out of Vancouver aircon and take you to Uganda without having to pay a flight. And so here we go. So we'll look at the national treatment policy in terms of the framework of the background and what is TASO, what do we do, and then the community mobilization models, just an intro, and then ongoing efforts and way forward. In terms of a background, TASO is the AIDS support organization, and it's a pioneer HIV civil society indigenous organization that has been doing HIV/AIDS service provision in sub-Saharan Africa for the last 27 years, and within a community-based approach to services. In terms of the background also, we know that for treatment scale-up there are challenges, 2014 and beyond, mobilizing people who have not yet got the symptoms into care and making sure that there is adherence and retention. We also know that there are challenges, especially in our part of the world, to do with weak health systems and community systems. But these also present opportunities, and we need to build on the past efforts to support the health systems. And under that, we need to look at how we can strengthen the community systems. And the people living with HIV/AIDS are an important resource in community mobilization for treatment and retention. And there are existing community services models that need to be scaled up, and we also are aware that there is a need as we go into massive scale up to decongest the health facilities, and Josephine has just taken us through the community drug distribution and follow-up services. So in terms of the national guidance and the guidelines, we are following the WHO recommendations, but also we've moved into the test and treat programming for most at risk and key populations. And the discordant couples, the positive partner is also once identified, tested positive. They are also to go on to treatment. Children under 15 years, pregnant women, TB, people with TB, HIV co-infection, also once tested positive, or also to start treatment. The CD4 cutoff has been raised to 500 following the WHO new guidelines. And currently, as a country, we are looking at adopting the guidelines. The Ministry of Health is leading in this process of developing the guidelines for PrEP implementation into policy. What are TASO's treatment as prevention efforts to date? We participated in the PrEP study sites at 2 sites, and there's ongoing participation in policy and guidelines dialogue at local level, national level, and international levels, and dissemination, ongoing dissemination of the PrEP study results and the new test and treat guidelines, and community mobilization. So when we talk about the community model, the purpose is to ensure that the relevant community members have engaged, and there is buy-in, and there's sustained ownership and involvement in the programming. And it starts with a process of community entry, community engagement, followed by the mobilization of the programs, and then there's continuous review and adaptation of the lessons that we learn for any of the programs, be it treatment, be it prevention programs like safe male circumcision, scale up, EMTCT, any of the programs and any of the communities. This is the process that we go through with any one of them. And at the entry stage, it's important that we identify who the community gatekeepers are. Those are the people that will be relevant in terms of giving us credibility and building the trust with the communities that we are going to be working with, the mapping of these communities and start of a process of information sharing and dialogue, and through the process of buy-in and engagement to ensure that we have linked up with the community systems, identified the peers as the mobilizers and champions for ongoing service delivery and mobilization. There is need for skills and an emphasis in the skills. We've heard about the discipline of emotional intelligence, and it is critical in community mobilization to ensure that there is connecting with the communities, building of rapport and building of the trust, which is very key. And as I'll mention later, in terms of ensuring that in the process of service delivery, this trust really is a pillar in terms of issues when they arise of threat to their safety. It's important that this process should have been done well right from the very beginning. It's also important to use the relevant channels of communication for targeting the groups. And here I must say that if it was in Uganda and there was an opening ceremony, there would have been some music and dance, and because that's the culture there. What do people connect with? So you've got to look out for what do the community connect with. But I'm very aware that in Vancouver, that's not the way you connect. So local FM stations, mobile phone technology, peers, and in these groups you've got to identify who the peers will be, that the rest of the community looks up to and has trust in, and can be the model that they will link up with and buy into your program. So, music, dance, and drama. Here's a photo from Karamoja. Karamoja is one of our hard-to-reach communities. They are pastoralists, and to engage with them, you really need to work on the messages being put in the mode of communication that they understand and will be able to relate with using their local language. The people living with HIV/AIDS have also a big role to play, and there are groups at each of our centers of people who have gone open and can share their experience with community members and are able to give a message from what their experience has been, and they are also trained to be the expert community facilitators to give information as has been guided through the trainings. And I think the WHO terminology for that is expert clients. It's also important to get people that have the facilitation skills to be able to communicate with the communities. So there we have a community facilitator trained and able to link up with the communities, and she's doing a home visit, and this most probably is a discordant couple relationship and following up on issues in the homes. For the men, there's the Positive Men's Union for male engagement. What are the issues that are pertinent to men and for male involvement, where you need to have a space for them to have sessions that relate just to the men. So there are also ways to engage with them, and there are opportunities for that, and that space is also provided. This is a model for the community drugs distribution. Josephine has already gone into that, but you reach out into the community towards an outreach where people can come easily and do not have to incur transport costs and do not have to take too much time away from their businesses and what keeps them busy in their homes. Discordant couples, there's need for regular and continued interventions in terms of interaction with the community, with the service providers. So we do have quarterly sessions where we bring them together to share their experiences and to give new information that is pertinent in their programming. In terms of challenges, welcome back from Uganda. In terms of challenges, community mobilization is a dynamic process, and there is need for adaptation and flexibility as we learn the lessons. Stigma and discrimination we've talked about already, and the process requires time and dedicated resources, and there are schools of thought that imagine that when you're doing a community program, then the resources you can afford to have the resources go down. But this also requires you to have budgets that are dedicated to ensure that these programs can run. And the people that run them also need to be reimbursed and facilitated. There's need for continuous capacity development. So it is a process. Community mobilization is a process, and it is important that this process is followed if there's going to be sustained engagement. And there's community involvement in ongoing adaptation of the methods. The community needs to be involved, because if the community is not involved, then you won't have the buy-in, and you'll find a situation where you're leading and there are no followers behind you. So there's also need for community facilitators that are skilled, and it is a continuous process, like I've said. It's also important to have the peer educators and the people involved motivated, and some of the non-financial motivations have been capacity building, the regular meetings, recognition of best performers, and regular interactions. I've also mentioned the need for the reimbursements if people are incurring costs to come for meetings or to do some of the services. It's important that reimbursements are considered and are budgeted for. But there's also opportunity for collective livelihoods, seed projects, because if there are people living below the poverty line, then you need to engage them in a way that they see there is a benefit overall, and seed grants have been a way in which we have been able to motivate some of them where we have the resources. In terms of future plans, we are looking at continuing, building on to what Josephine presented in terms of other implementation research studies with partnership. We are also looking at continuous quality improvement and innovations to improve to maintain the quality of services and community engagement across the various programs and interventions as may be, and partnerships. We are looking at seeing how do we scale this up at a national level, but even over and beyond our country. What are the opportunities we have to share these experiences beyond TASO? And we had started on such a program supported by SIDA in the Sub-Saharan Africa region, and we look for more opportunities. That project closed, and we look for more opportunities to do that in future. My final thoughts are that for success of further treatment expansion with limited resources, community-based models are a vital and ready resource to maximize and tap into. And I would like to acknowledge the Ministry of Health, our clients and staff, community partners, the workshop organizers, UNAIDS, and the people that have funded the programs that we do. Thank you.